Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So, to introduce our speaker, Dr. Kirlew, born and raised in Canada's capital city, Dr. Kirlew attended the University of Ottawa for both medical school and his residency. After completing his residency, Dr. Kirlew worked as a rural generalist in Sioux Lookout, Ontario, and Moose Factor, Ontario, before returning to his roots at the Bruyère FMC in Ottawa. In addition to being a practicing primary care physician, Dr. Kirlew holds academic appointments at the Northern Ontario School of Medicine, Queen's University, and the University of Ottawa. So please take it away.
Sorry about that, everyone. Great to be here today, and thank you so much for that welcome. It's great to be able to present at Grand Rounds. Just going to share my screen here. So much, everyone, for coming to Grand Rounds. It's great to be here. Great to be here today. I'd like to just do just to reiterate the land acknowledgement that we're on the traditional territory of the Anishinaabe Algonquin people. What are going to be some of our objectives today, right? What are we going to be talking about? Well, I'd like to focus a little bit on the challenges of rural and remote medicine, as well as the interim results of an evaluation of a course that we've been doing for the past number of months here at the University of Ottawa, right? So we're going to be talking about that course. All right, so I'd like to start off first with sort of providing a little bit of background on rural and remote medicine. And we're going to use two different case studies, just very briefly, of two places that I've worked. I've met some phenomenal individuals there, and it was really an amazing place. I started off my career in Sioux Lookout, Ontario. So I did there for about 15 years and spent about 3 years in Moose Factory. I'm still working part-time in Moose Factory. Wonderful location. So I thought we'd kind of look at a bit of a case study on both of these environments and what are some of the challenges in rural medicine. Okay, and I've always liked the idea of guiding principles, right? Like what are going to be some of our guiding principles that we're going to use today? And I believe in the power of storytelling, right? I feel that we can really convey ideas effectively when we storytell, right? As opposed to just sort of listing off bullet points off of a PowerPoint. So I'm going to share some stories today. I'm going to share some of the truth that I've witnessed working in the North. And I want to have these two guiding principles that we have. So the first one is medicine is not only about content, but context. The right answer in the wrong context isn't the right answer anymore. And I have a story to tell about the context, and I'm going to share about the very first time I actually had to intubate somebody in Sioux Lookout. So I remember I just started working there. I was maybe 2 or 3 weeks into my stint in Sioux Lookout, and we had somebody that required intubation. They required intubation. We thought they had a pneumonia. This was the first time I had actually done this in a rural and remote based setting. And I remember I did it. I got my medications. I got all my equipment prepared as I had trained over residency too. And I remember going through my checklist in my mind of the various procedures that we do before intubation, making sure I got my medications, making sure that I had my primary method of intubation as well as an appropriate backup. At that time, it was an LMA. And I brought the crike kit out as well too, just in case I needed it. And I remember going through in my mind mentally through the entire checklist or so. And I remember getting to the patient and I remember pushing my medications. And I remember doing the intubation. I still remember the tube going in. And I remember thinking to myself, yes, I got the tube in, my first intubation as a full-fledged staff. And I felt great. And I remember after I did the intubation, I remember connecting the circuit to the actual bag and mask itself. And I remember starting to bag and mask the patient. And I remember I asked one of the nurses there, it had been about 5 or 10 minutes or so, and I'd been bagging the patient. And I remember they rolled up this machine and they said, well, it's time to connect the ventilator. And I said, well, that's great. That is awesome. Congrats. Let's connect this ventilator. So we just need to contact the RT. And I remember the nurse looked at me and said, we don't got no RT here. And I remember literally kind of feeling like I wanted to roll up in a ball. Because I remember I had done rotations in the ICU, and we always had a respiratory therapist. And I remember thinking to myself at that particular moment when they had literally just rolled up this piece of equipment that I had never seen before, I realized that, oh man, I've done all this training, and look, my medical education did not match the context that I was practicing in. And you know what? It kind of underscores our next statement as well, too, one of our mission statements. And we can say, you can know a lot of stuff. And I remember an ICU mentor told me this. You can know a lot of stuff, but at the end of the day, you need to know what you need to know. And I remember, so we got the ventilator, and I remember getting and kind of figuring it out. It took a while. And I remember at that time, I was like, oh man, I'm not sure if I'm doing this correctly. I called on the phone for someone to give me a hand. This was unlike any ventilator I had ever seen before, right? It looked analog. I was used to touch screens in the ICU, and this looked like a calculator from about 1974. And I remember when I was connecting the ventilator to oxygen, I remember something struck me at that particular point. That I was so used to the oxygen coming out of the wall. I remember when I did my training at the Civic and at the General, and even on rural rotations, the oxygen always came out of the wall. You'd have the flow meter, you'd kind of crank that little dial up, and you'd be able to get this unlimited flow of oxygen. And I remember connecting this ventilator to a tank of oxygen. I remember thinking at this point, wow, this reminds me of shop class, back in high school. It's like, this looks like it should be connected to like an acetylene torch or something like that. And I remember I had a situation where I didn't realize with that ventilator connected to that oxygen tank that tank could run out. And I still remember the nurse calling me saying, the patient's saturation is 74%. What do we do? What do we do? What do we do? And I remember going through my troubleshooting, everything that I had learned in residency. And the issue is that the oxygen tank ran out. So I think that story kind of conveys our two kind of mission points for today. Medicine is not only about content, but context. And the right answer in the wrong context isn't necessarily the right answer anymore. And at the end, so we need to make sure that what is the context that our residents are going to be learning in? Because yes, you can go and you can train in a tertiary care center and you can get very, very good. And as we said, our second mission point, you can know a lot of stuff, but at the end of the day, when there's no RT, do you know how to turn on the ventilator? At the end of the day, do you realize that a lot of hospitals do not have this sort of endless supply of oxygen or so? And we have to make sure that we manage those things. Just going to move on here. I always like to point on, I'm not sure if people know who this is. This is Josiah Fidler. He's a hero of mine, a fantastic human being. In Sioux Lookout, where I started, you know, we all know about the effects of systemic racism and the effects of colonization within the healthcare system. And Josiah Fidler in 1988 led a hunger strike to protest the conditions at the Sioux Lookout Hospital at that time. Because he realized, and his experience was, that Indigenous people receive a far inferior level of healthcare than everybody else. And he had the courage to take those advocacy steps. And he led a hunger strike. And this is not, we're not talking about this happening 100 years ago. This happened in 1988 and 1989. And that hunger strike led to a very famous report in the region that recommended significant changes to the healthcare system at that particular time, and led to the creation, we're going to see in a moment, of the Sioux Lookout First Nations Health Authority. So I really appreciate Josiah Fidler's courage in the face of adversity. And he, to me, exemplifies advocacy. And he was a wonderful human being. You know, I had the opportunity to actually meet Josiah Fidler before he passed away, and he was really a remarkable human being. And with these sessions, what I hope to one day accomplish is really kind of the spirit of Josiah's, in that spirit of advocacy, making sure that residents use their position of privilege as a healthcare provider to advocate for their patients and stand up for justice in the face of these inequities, just like Josiah's. So I always like to put that little preamble there and stuff, and he's a real hero of mine. So let's continue on. I'm just trying to get the, can everybody hear me okay so far? All right. Okay, let's talk a little bit about the Sioux Lookout Zone. When you're looking at the Sioux Lookout Zone, you are looking at literally a landmass the size of France. So Sioux Lookout Zone and Moose Factory Zone is 9/10 of the province's landmass. So you can see here it's representative. So there's a number of communities within this zone, and the main sort of referral area is Sioux Lookout. And there's about 33 Indigenous communities spread over this area, literally the size of France. So we're talking about a massive area, massive area. Now we have two major, there's the Sioux Lookout First Nations Health Authority, and there's also the Sioux Lookout Menoyawin Health Center, which is the main hospital in Sioux Lookout. Now, I'm just going to move on here and just going to move on here and stuff. So 33 First Nations communities, Sioux Lookout Menoyawin Health Center serves as your primary referral center. And you have very, very limited access to specialist services. Hardly any visiting specialists, and a catchment population of about 30,000 people. Now, this is another thing, is that, you know, the communities are between 300 and 800 kilometers north of Sioux Lookout. So, you can have communities that are like Slate Falls, which is, an hour plane ride, about 250 clicks away. But then you also have communities like Fort Severn right on the Hudson's Bay coast, that's 750 to 800 kilometers away. So just to keep the idea of the distances that we're talking about, and these communities are fly-in only. So there's not access to an all-season road. Now, how do individuals access healthcare in the northern Indigenous communities is through the nursing station. So this picture that you see is a picture of the Pikangikum nursing station. And this is it. This is where healthcare happens. This is where all your primary care is going to happen. But as well, any emergency that comes in, any child that needs to be delivered, any trauma that comes in is going to show up on the nursing station's doorsteps. Now, and the thing is that nursing stations themselves, they're not always staffed by a physician. There's usually nurses always there, but they're not always staffed by physicians. So when you work in the practice of Sioux Lookout, you spend a portion of your time at the Sioux Lookout Hospital doing things like hospitalist, looking after inpatients, delivering babies, working in the emergency department there. But a portion of your time you will spend in the northern communities. Now, so at the nursing station, individuals access primary care as well as any emergency services. And physician services, physicians are not always in the northern communities. So in some communities, they may have 10 days of physician coverage every month. So what happens is that those communities themselves, they'll always have nurses that are there, and physicians will cover via the phone or via OTN. So very different structure of sort of the healthcare system. And remember, at the nursing station, that is the point where everything is going to show up. Everything from a primary care visit to hypertension to delivering twins at 34 weeks. Everything is going to show up at the nursing. Everything is going to show up at the nursing station. Now, what are some challenges here? And I'm doing this to paint a picture because our residents work here. Our residents, after they graduate, this is the environment that they're going to find themselves in. There's no access to in-house specialty services. So at the nursing station, there's no visiting specialists or very few visiting specialists. You have limited supplies of medication. In addition to, inventory management systems are not like the same down south, in that oftentimes you can run out of stuff. You can run out of sedation, run out of fentanyl, run out of ketamine. There's limited supplies of consumables that we don't even think about in Southern Ontario, things like oxygen. So even before COVID, we had individuals who ran out of oxygen in the northern communities. There's no ambulance services or adequate sort of pre-hospital services. And you imagine too, remember we talked about the distances that we're talking about here are 300 to 800 clicks away. So that means when you have a really sick patient, to get them out, it can sometimes take days to get the patients out. And you're limited by things like distance and weather. So there are significant challenges that, as we said, remember one of our mission statements, that medicine is not only about content, it's about context, that this is an environment that is a unique context. All right, now let's travel. That's the northwest end of the province, right? That's an area the size of France, kind of north of Thunder Bay. What about the northeast part of the province? So this is where I currently work now in Winnebago Area Health Authority in Moose Factory. Now, where is Moose Factory? Moose Factory is on the James Bay coast. It's on an island, and the hospital is located on an island. And there are a number of communities along the James Bay coast, similar to the situation in Sioux Lookout, smaller communities. And physicians fly into these communities for a few days every month. And then nurses are there the vast majority of the time. So a very, very similar setup. But this side is set up on the northeastern side of the province, and it's run by the Winnebago Area Health Authority. Now, this is the hospital I work at. This is the Winnebago General Hospital. Now, this hospital has an interesting bit of history, and is that this hospital was built in the 40s, and it's in desperate need of renovation. Now, thankfully, the communities were able to advocate for the federal government, and finally, they're going to be willing to fund a new hospital that's currently being built right now. But this is the Winnebago Area Hospital, and it's located on Moose Factory Island. Because the original purpose of this hospital, just like the original purpose of the hospital in Sioux Lookout, was based on isolation from tuberculosis. So building a hospital on an island for the purpose of, I remember when I came there at first, I'm like, why is the hospital on an island? Because when you're trying to isolate people from TB, when the goal of your healthcare system at that time was influenced by things like systemic racism and the effects of colonization, that's what was your healthcare system. The other thing about this hospital is interesting, even now. There's no elevator. And if you guys look at this picture, you can see, if you look at this picture of the hospital, there are 3 stories there. There are 3 floors. There's the ground floor, and that's where the emerge department is. And then the second floor, that's where the inpatient unit is. Now you might be wondering, well, Mike, why are you talking about the layout of this hospital? Because for me, this layout embodies the effects of systemic racism and the effects of colonization, how that can impact even effects now. And these are not past tense realities, but these are present tense situations. That if you look at that, if I have a multi-story building and people are coming into the emergency department and they're being admitted to the second story, then how do they get from the emerge to the second story when there's no elevator? There's actually a ramp. And patients have to wheel themselves up, or people have to push people up in the stretcher up a ramp. Now in Southern Ontario, guarantee everybody, a ramp would not fly in a multi-story hospital. When you have to move oxygen tanks, which are essentially cylinders of compressed flammable gas, right? Like these things are essentially missiles if they fall over. If you have this thing on a dolly and you're going down a ramp, you hope to God, it's not going to get away on you. And isn't it interesting? Isn't it interesting that a resident pointed this out to me? I went there as a resident and I didn't notice the fact that I was going up a ramp to get to the second floor. When I started there as a staff, it didn't connect in my mind that I'm going up a ramp to getting to the second floor. It was a resident that I was working with that said, yo, like how come there's a ramp and no elevator? And I was like, yeah, that's the way things are, It didn't connect with me that was an issue. And I remember the resident told me something at that side. They said, isn't it interesting that some people, because of colonization and systemic racism, have to work so hard pushing. Imagine that patient wheeling themselves up that ramp, or that person on a stretcher and you're wheeling them up a ramp. That some people have to work so hard to get to the same place that other people press a button and get carried to. I just want to point that out. Because, one of my goals in this simulation curriculum is to talk about, as we said, Josiah's advocacy. It's not all intubation and vasopressors and LTV ventilators 1200 and working with Orange and how to contact coroner's dispatch or how to arrange for a blood transfusion when you only have 4 units of blood, or to realize that rural centers don't have platelets. Yes, we're going to talk about those nuts and bolts, but it's realizing and getting residents to appreciate how they can use their voice and how they can use their privilege that comes with being a physician to advocate and to work with communities to advocate for better healthcare funding, better healthcare resources to ultimately improve outcomes. Because every time I take a resident up with me to Moose Factory, I show them the same thing. And it's interesting how that you can be going to a place forever or for a while and not notice the inequity right in front of your nose. I had been going there for years and had not noticed that inequity right in front of my nose. Sometimes it takes a fresh set of eyes to point out what's apparent in front of our face. All right, just to kind of go through, I want to point this out because it's you know, I'm passionate about advocacy and how does one actually transmit that and encourage residents to see the importance of that, especially in these environments or so. So this is just an example of where we are. You can see Moose Factory on the map there, right at the base of James Bay, and there's a number of northern communities. So similar setup to Sioux Lookout. The other point of difference is as well too you know, the population at the Sioux Lookout zone is about 30,000. The population in Moose Factory zone is about 10,000. So about a third as big, right? Again, this is another example of, you know, what do we say? One of our guiding principles again, you know, medicine is not just only about content, it's about context, and the right answer in the wrong context is not the right answer anymore. We also have our rounds with our residents, and we talk in our critical care course about certain conditions that are unique to the environment. I'm just going to play this video for everyone here, and it's just a video here. So this child, and this was received with permission, and there's no identifying features, came to the clinic in Moose Factory, claiming to the clinic in Sioux Lookout, and you know, with a concern of, you know, ticks. The teacher said, yeah, you're having some ticks. Go get the doctor to check you out and stuff. So we saw this child in clinic, and these are some of the motions that they were doing. I think the video is just finishing off there. It's a short video. But this condition is very rare in Southern Ontario and very common in the North. In fact, 75 times as common as it is in Southern Ontario. And this condition was responsible in certain years. When we went through our pediatric resuscitation modules, this condition was responsible for more pediatric shock some years than sepsis. And I know we can't have, you know, sort of a show of hands, or it's difficult to kind of do that, but I'll break sort of your suspense. This is a condition that we talk about a fair bit. This child has Sydenham's chorea. And Sydenham's chorea is from rheumatic fever. And that's what it looks like. I'd never seen that in medical school. I had never seen that in residency, and we see it relatively frequently up north. So again, medicine is not about content, it's about context. So it's also about getting residents to realize what are some of the local epidemiology patterns of where you're going to work. So part of it is not only intubation and ventilators, but it's also, well, if you're going to be working here, speak to some of the doctors who are there to say, what kind of conditions do you see? What sort of presentations that are common there that may not be common in a Southern Ontario sort of environment? Okay. All right, so critical care simulation focus in rural environments. So we talked a little bit about, you know, what the environment is. What are some of the challenges? And I wanted to see, you know, is it possible to sort of develop a rural remote care curriculum at a tertiary care, predominantly tertiary care, large city program? And using the principles of high fidelity simulation, one of the things that we have in Ottawa that is just fantastic is that we have the Ottawa Skills and Simulation Center, the amazing sim lab right at our disposal there. Is it possible to using things like high fidelity simulation, using things like task training, so that residents can practice certain tasks, like things like intubation, IO insertion, PICC line insertion? Can they use pieces of equipment that they're going to encounter in a rural and remote setting? And they are able to operate it in a rudimentary way. Are they able to operate it in a rudimentary way without a respiratory therapist? And sometimes it can even be simpler than that. Sometimes it can be like, well, how does the corner system work? What number do you call? I remember as a resident not understanding that until after the, oh, wow, they just brought this person who was deceased into the emergency department. What do I do? There's a number that you call. How do you initiate a transfer with critical? You know, rotating through emergency blocks, you're going to get that exposure to receiving sick patients from tertiary, from peripheral centers. But when you're at the peripheral center, how does the logistics work of transferring that patient out? So simulation is not just task training and not just running through the nuts and bolts of various situations and seeing how they apply to that rural context like we talk about. It's also those nuts and bolts of what number do you call to access coroner's dispatch? How do you arrange for things like someone wants to donate organs, right? Like, how does that work in a rural context? How does it work to arrange to get a person to a medical facility? I had no idea if residents would find this interesting. I'm like a rural generalist. Like I'm like props rural. Like I think rural generalism is the kick-ass, most badass specialty on the planet. I'm sorry about that. You know, I love it, you know, so I'm really passionate about it, but I have no idea if residents are going to find this useful. I don't know. We did a preliminary session. It was interesting in May. It was very informal, and notice I put informal in the brackets. Very, very informal. Got the sim lab booked. We could get it booked for free at that time, and we invited some of the second years, you know, the second year residents at the to kind of say, hey, if you want to hang out, we'll do some resuscitation. We'll run some simulations, that type of thing. And the initial feedback was pretty good, but again, it was informal. I wasn't thinking about evaluations or research projects or anything like that. I just love teaching and love working at the sim labs. And then the opportunity sort of came up to kind of say, well, maybe, because there was much more interest than I initially anticipated, maybe there was an idea to maybe we could try this on a slightly larger scale. And it was interesting. I working with a great resident, Narob Saha, and he was like saying, hey, you know, he's working on this residency, you know, his residency project. And we said, yeah, let's see if there's an opportunity there. And it was cool because he sent out an initial Facebook post on sort of the residents' Facebook page, you know, to kind of gauge sort of that initial interest. And this is some of the examples of what they did. You know, hey, you know, this is a course we're just trying to create. It's very preliminary right now, but is there an interest in this? And there seemed to be on Facebook. There was a pretty good interest so far, at least on the channels that the residents communicate through. So, we were able to get emails sent out to invite all the residents and all the programs. And it was interesting. We had 62 people express interest. That was way more than I thought. Way, way more than I thought. I was lucky if we would get like 8 people, right? And that was kind of the breakdown that you see before about, you know, PGY2s were 39%, you know, PGY1s were 60.3%. We're like, okay, there's some interest here. Unfortunately, I couldn't opt like 60 people to go through court. Like, there's just not enough people to do that. You know, I was just like, well, let's just try it with the PGY2s. All right, let's move on here. We also asked as part of our sort of initial surveys, you know, do you have an interest in, like, where do you see yourself kind of working in the future, right? It was just a survey just sort of to gauge interest. We just asked a series of questions. These are some of the things. Do you have an interest in working in any of the following settings in the future? Academic ER, 25.8%. Okay, so some people might be interested in their 3rd year of an ER program. Academic ICU, not many people. Academic hospitalist, well, 40% of people. Rural ER, 85.5. Rural ICU, 38.7. Rural hospital is 82.3. Like 51% of participants like listed that. They could list multiple things. So if you kind of look at that, there's a lot of people interested in emerge, especially in a rural context. As well, too, look at the other big bar, rural hospitalist as well. Let's ask, we also ask this question as well, too. Do you have any experience working in any of the following settings? Again, this was just the preliminary stuff. We're trying to say, like, where are people interested in working? Just asking very general questions. A lot of people, oops. I'm sorry there, I advanced a bit too rapidly. Yeah. A lot of people were interested in academic emerge, right? A lot of people look at their experience, right? Like, this is where people want to work. They've expressed a lot of rural. Look at where they got experience as academic ER, academic hospitalist. Thankfully, there was a lot of rural ER at 65.4. So we noticed kind of a little bit of a gap, right? And we almost expected that, right? Like, a lot of people were interested maybe in working rurally. But their experiences were not, they were not mirroring those with equivalent sort of rural kind of experiences, right? Okay, let's move on. Okay. So we were able to get, in the fall of 2023, try this little simulation course. Now, what we wanted to do was sort of develop something that would kind of build, like each session occurs once a month, approximately. So we planned for about 9 sessions to happen over about over 12 months, just so we could account for things like the holiday season, et cetera, and stuff. So they usually happen about once every 4 to 6 weeks. In addition to, because one session kind of builds on the other, we said, if residents want to do this, you have to be prepared to do all of the sessions, right? Because it's not just like you do one, you know what I mean? Yeah, you might get some benefit and stuff, but they all kind of build on what we discussed previously. So you commit by doing all the sessions and stuff. So we planned 9 sessions over the about 12-month period, beginning in September of 2023. Focus on the PGY2s. We gave everybody the opportunity with those caveats that, you need to be prepared to do all of the sessions. Simulation sessions occurred at our friends at the Ottawa U of O Skills and Simulation Center and stuff. We did them in the evening to make it easier to schedule, right? So we wouldn't have to get residents out of clinical activities during the day and stuff, All sessions were located at the Ottawa Skills and Simulation sessions, and the sessions kind of built on one another. So they weren't like one-off sessions. It was designed to sort of be 9 sessions that kind of build on one another. So let's look at some of the objectives and what is some of the data that we've collected for the 3 sessions. We just completed our 4th session, actually, in February and stuff. So far, let's see what some of the data is showing. All right. So session 1, we talked about, just to inform us some of the objectives of the session, we talked about an introduction to respiratory failure. We talked about ventilators in this particular session as well, too. And we talked about how you arrange transfers. What is actually the logistics of the critical process, right? How do you know what number to call? And when you first contact critical, what kind of information do you give them? And who decides where a patient actually goes to and stuff, right? And you can see the above graphs list kind of before the session, and the bottom graphs sort of list after the session. So we did kind of pre and post session surveys. So you can see here and stuff, we got this is the thing, a lot of people, don't really have tons of experience, for example, using critical. And then we notice big gains, for example, that people felt that they have more understanding of the critical sort of system and stuff. Look at respiratory failure. And respiratory failure happens a lot in rural medicine because you need to be able to flex that vent. You need to be able to BiPAP people, because that happens in relatively frequently, and you're working in environments potentially with no RT. So a lot of people, this 1 to 2 means comfort level and stuff. No one reported 5. Very few people reported 4. You can see 3, 2, and 1. So not very confident. And we're seeing after the session a bit more confidence. And keep in mind, this is not like the only time we talk about respiratory failure. We start on it on one session, and we add additional concepts on this idea of respiratory failure throughout the sessions. Let's take a look here and stuff. What's your level? Look at the third one. What is your level of confidence in operating a ventilator without the support of the respiratory therapist? Pretty well everybody said, I'm not confident at all, right? I don't, I've never done it before. Remember, these are PGY2s that are a year and change through their residency, and pretty well, everybody's reporting a 1 or a 2. I haven't had lots of experience doing this. And after finishing the series, what is your level of confidence in operating a ventilator without the support? We're seeing some gains there as well, too. Let's take a look at session number 2. Some of the feedback that we got here, we got really positive feedback overall. Really positive feedback about the sessions or so, and about the quality of the sessions. Let's take a look at session number 2 and stuff, which ran in October and stuff. Again, this introduced slightly different concepts of mechanical ventilation and using your ventilator. In addition, we talked about pediatric airways and introducing how do we manage the pediatric airway and stuff. And again, we talked about intubation as well, too, and medications. We expanded it to medications for sedation as well, too. You can see the pre-surveys above, and you can see kind of the post-surveys below. So we're definitely seeing more confidence, a little bit more confidence, at least self-reported, more confidence after the session. And that's why I like the idea of having kind of regular sessions sort of spaced out over a period of time. Because sometimes we do a course like ACLS and ACTLS, and we do this intensive thing for like 2 or 3 days, and we feel like an expert afterwards. But the problem is that you may not be practicing this stuff on a day-to-day basis, right? You may go months without intubating somebody. So it's better to probably, inject the idea at regular intervals throughout a training program. Let's take a look at session number 3 here, just some of the data that we've had so far here. So again, these are just some of the comments that we've had or so. This is some of the comments that we've had from some of the participants of the sessions and stuff. Take a look at session number 3. We talked about Optiflow. How do you use the non-invasive how do you use high flow nasal cannula, right? How do you use that? When do you use it? We again expanded on intubation as well, too. And we introduced the ideas of vasopressors and stuff. So vasopressor sort of basics, right? And again, we're seeing above is kind of before the session, afterwards is kind of after the session. So we see sort of this general trend of sort of people generally on most things feel a bit more confident before than after, a bit more confident after than before. And so same kind of trends that we're seeing. Again, this is just some example of some of the feedback that we've gotten so far and stuff for session number 3. So excellent. So what we hope to do in the future, we're still kind of halfway through our pilot here. So it's super exciting. We've completed 4 sessions so far as of February. So we're going to have another 5 sessions and stuff before June. Really good, exciting news that we were able to get some funding actually from the Winnebago Area Health Authority as well for the sessions to continue until June of 2024 and stuff like that too. So it'd be interesting at the end of the year when we get some data on kind of, because I'd love to kind of collect some data and look at like, are people trying out a rural and remote locum, or more likely to try out a rural and remote locum and stuff like that. So it'd be interesting to kind of follow people through time. Just want to give a couple special thanks. I think my time is almost up there. Department of Family Medicine, Dr. Ed Seal, thank you very much. Amazing resident extraordinaire, Narob Seha. He is fantastic and stuff. Got to give him some props there. Ottawa Skills and Simulation Center. Special thanks to Chandra, who's always arranging the sim lab and helping get emails to residents and stuff like that too. And a big shout out to the Winnebago Area Health Authority as well. And just to kind of tie in this idea, I know we talked about a lot about advocacy. Like, we're going to have sessions as well, too, about how to advocate for your patient on the phone. Like, how do you even get a patient once you've established that connection through Critical? And you have to now convince a specialist in tertiary care center X that your patient is sick. and that specialist likely has no idea about the context that you exist in. So how do you actually do that, or what are some tips about doing that effectively or so? Excellent. That's any I think that's it. That's all that I have. It was great. I think we have a what is it, 8:46 now? I think we have a few minutes for questions.
Yeah, if anyone has any questions, please raise the hand on Zoom and we can go by like an order. So we have a question from Claire. Dr.
Sure.
Liddy.
Yeah.
Good morning. Thanks so much, Mike. Fantastic work. So there's two, I guess, comments that I wanted to make. The first thing was I thought it was really fantastic how you laid it out. I learned so much this morning, and really that's the point of, I think, the work that folks are doing to then be able to share. So great work. I want you to keep going with it. And I'm just wondering, what can the Department of Family Medicine do to further support this? How can we support, again, a bit of a write-up so that this can be shared once you're finished your simulation? Are there any resources in terms of additional budget and also staff time that would be helpful? So you don't have to answer all of that right away, but I think I just want to invite you to do a follow-up with me thinking about those types of things. And kind of what comes next. So fantastic work, really impressed. I appreciate all the energy and the context that you set, I think, for all of us. So well done.
Oh, thanks.
So please follow up.
Okay.
We have our next question from Dr. Mirdavudi.
Thank you. Hi there, Michael. I just wanted to introduce myself. I'm the new Director of Faculty Development. So one of the things that was running through my mind, this was really inspiring. How can, to second what Claire said, feel free to reach out also to me. How can we help develop the people training the residents? Do you think, there's any resources you require from that, or just let us know?
Yeah, sure. That would be fantastic. To kind of develop it, or yeah, I think that would be that'd be great. To be able to access those additional resources. I always say I'm not like an academic. I love teaching but I don't understand a lot of the researchy type stuff. I'm kind of a very pragmatic kind of, you know what I mean? Like, I love teaching, I love going to the sim lab, but I think if I get more to kind of to look at sort of the researchy sort of end of the things, I think that would be, and especially looking at some of those longer term outcomes, and looking at things like, how do we teach advocacy, right? Like in sort of an Indigenous context in the North, right? Because, I have some scenarios that I plan to do in future sessions, but, I kind of want to look at that a little bit more, so.
And that's my angle, really, not even from the research side so much. Are there enough faculty helping you on your mission to sort of teach the residents and inspire them from the rural perspective? Are there skills that you have as a teacher from the clinical side that you think, the others would benefit from picking up from you as well? Is there sort of an angle on that side of things?
Okay. Yeah, I remember the University of Ottawa used to do a course, I remember years ago, the ACES course. And I think that was a phenomenal first step. I remember this is going back 15 years or so. And it was great. It was kind of the fundamentals. I was one of the developers for the ACES course for the Department of Family Medicine. It was initially sort of a critical care ICU course that was kind of tailored more towards, in a family medicine type setting if you're working as a hospitalist. So I think the faculty already has sort of experience kind of doing that because, you know, there was a big push to kind of get all the residents to do that course, and there were a lot of faculty that were trained and stuff. I'm not really sure what kind of happened, you know what I mean, and stuff. I'm not, you know, I was kind of away for a bit, so I don't really know what sort of transpired. But you know, the faculty definitely has had sort of this, and that was years ago. Like we published on this, but like in 2008 or 9 or something like that. So this is going back, you know, 12, 13, 14 years ago. So the idea of sort of critical care and using simulation and sort of adapting it to a family medicine into kind of a rural generalist sort of concept, you know, the department has been doing that and did do that years gone by and stuff. So, you know, really all they did was just sort of take the, you know, you can look at the ACES course and then just sort of say, well, you know, instead of just having like a 2-day event, you know, let's try to see if we can spread it out. Like basically if you have so many hours to give, instead of giving like, you know, 12 hours for 2 days, kind of spread it out and then kind of make the sessions build on one another and stuff, right? So residents kind of get that ongoing kind of horizontally sort of curriculum type of you know, little boluses of rural sort of based critical care. Yeah. Excellent. I think Teresa has a question, or
yeah, hi. Mike, congratulations. What a beautiful and exciting initiative. I'm very excited. So a couple of ideas, just bouncing off what Claire, and sorry, I didn't catch your name as our new Director of Faculty Development. I wonder if you want to, first of all, present at DIME rounds. Department of Innovation in Medical Education, that's where I did my fellowship, has the one part which is called FEAST, which is Foundation of Education Using Simulation for Teaching. And that part, every year, they essentially has medical educators. Hi, Vera, there you go. So they have anesthesia, OB, and gen surg and emerge physicians who doing a fellowship in DIME or FEAST. And as part of your project, you actually have to develop simulation scenarios. And I do know that the Sim Center, you could also reach out to Glenn Posner. I can put you in touch with everybody. I'm actually in the process of getting my cross appointment with DIME so that I can be more involved with them. But Glenn Posner, as the director, can put you in touch with essentially these residents so that you could use them as your labor to formalize the curriculum, because I think it's really important in order for you to disseminate this, and you need a formal curriculum development. And each piece of, as someone who's developed a curriculum, you know, each part needs to be well established and organized and evaluated so you could actually use them. And the reason why I suggest we do that, because remember when we call, there's the other person on the end who also is not familiar with the context that I am working in. When I worked in Kirlew, 90% of times, I fell on faculty who had never been up north. When I was lucky and I was working with someone or talking to someone who had come up as a specialist, it was a completely different experience. So there's actually something for them to also gain. And this would be a piece of pride and joy for us to come back to DIME as family medicine, because we're no longer part of DIME, but we could actually wedge ourselves back in through your leadership. And I'd be more than happy to support you so that we can start interdepartmental collaboration again, so that we give experience also to their residents and their faculty, and that way use their labor instead of burdening just us. That would be a great collaboration that we can do. And some of the work I've done has always been with fellows and medical residents, and it's a great opportunity, and they're eager to publish. so they can also help you. And there's every year there's also a 10,000. I know it's little, but it's a 10,000 grant through DIME that you can apply for example, next year to formalize it. Unfortunately, the deadline is done. So definitely write to me and I'll put you in touch. But for both Claire and Vera to kind of consider in terms of how we can collaborate with DIME. Sorry, it was a long rant.
No, that was awesome. Thank you so much, Parisa. That's very insightful.
Oh, thank you. As long as there isn't anybody else. Yeah, just in follow up. So, I mean, we do collaborate with DIME. I think what Price is talking about is that we had stopped our contribution to, that was like an annual thing, because we keep the money within our faculty development fund ourselves for better support, but very interested in supporting, and people are doing the health education scholar program supported by the Department of Family Medicine with DIME. So definitely the interaction, and as you said, working with other people from the different clinical departments can be very enriching. And then the other piece, that might sound daunting, what Parisa said, but I always encourage people to think about the long game in terms of over several years. When you have ideas that you're implementing, you're a just do it person, Mike, which is amazing. I think that's high value, and it's not less valuable than other approaches. It's just a question of how you can share it and then put it into the context of formalized medical education, because that will, I think, enable what we want to do is take great ideas that look like they're working well, that have a very good foundation and high impact for patients, and then we want other programs and other residents to be able to benefit from it outside of our institution. And also, there's an international relevance here in terms of culturally safe and delivering better or equitable healthcare for Indigenous populations. So I think that what you're thinking about, how you present it, the work that you've already done is highly valuable and should be shared, and could in fact have like a long-term impact on, thousands of students. So great work.
Well, thanks.
Claire, if I may add, I can't thank Sharon Johnson and Claire Kendall, who mentored me to formalize some of my clinician teacher ideas into something that became more formal. And again, same thing, the department funded for me to do the fellowship. So these are the things that, Mike, that you could think of in terms of developing this to a long-term program of research, but certainly collaborating with some of us who've been around a little longer and have more of the pulse of the research on board. As Doug, who I think is not here, always says that, research is a team sport, and we're here to support you. I'd be delighted to collaborate with you and give you a couple of cents that I have, certainly in terms of making this, given that, again, I have my write-up of my curriculum, you could just essentially kind of copy the blueprint and use that. That's what collaboration is all about. You don't need to invent anything from scratch, but we can certainly help formalize it for you.
Oh yeah, that would be fantastic. That if those resources already exist, that's amazing.
So I just wanted to thank everyone for attending this FMGR. Our next FMGR will be featuring Dr. Nathan Shirley from Winchester and also Dr. Frank Nofal, and will be held on March 28th. So looking forward to seeing everyone there.